Have you ever felt that nagging jaw pain, or maybe a weird clicking when you chew, sometimes stiffness, stuff you just kind of tried to ignore?
Yeah, it's surprisingly common, isn't it? But often really frustrating, and people don't talk about it much.
Exactly. Well, that discomfort, this whole puzzle in your jaw, it actually has a name. Temporomandibular disorder. TMD for short.
It affects those crucial temporomandibular joints, the TMJs, basically the hinges connecting your jaw to your skull.
Okay, so let's unpack this. In this deep dive, we're going to sift through what the experts are saying about how you can manage TMD without jumping to surgery.
Right. Our mission here is really to give you a clear, comprehensive picture of the surprising range of non-surgical treatments out there.
Yeah, cut through some of the confusion, help you feel, well-informed and empowered.
We'll explore pretty much everything: lifestyle tweaks, medications, physical therapy.
Those special dental appliances, too.
Oh yeah, definitely. And even some more advanced strategies. We'll also touch on why sometimes these treatments don't quite hit the mark and what that means for you.
Sounds good. So let's start right at the beginning. What exactly is TMD? Who tends to get it? And why is it so complex?
Okay, so TMD is really a general term. It covers pain or dysfunction or both of the TMJ and all the bits around it, muscles, ligaments.
So not just one specific thing.
Not really, no. Think of it more like a catch-all for various jaw issues. And what's surprising is how many people it affects. Up to 5% of the population.
Wow, 5%. That's actually a lot of people.
It is. And it tends to show up more often and sometimes more severely in women and in older adults.
And I hear the causes can be all over the place. It's not just like one simple trigger.
Precisely. The causes are really multifaceted. You see everything from direct trauma, maybe a knock to the jaw,
Right.
to what we call parafunctional habits, things like grinding your teeth, clenching your jaw, often completely subconsciously. Yeah. It could also stem from malocclusion. That's basically a bad bite where your teeth don't line up quite right.
Yep.
Or even just overloading the joint.
Okay.
And then you've got things like arthritis playing a role. And what's really fascinating, even psychological factors are involved.
Psychological factors. That really underlines that whole mind-body connection, doesn't it?
It really does. The best way to think about TMD is often in terms of interdependence.
Interdependence.
Yeah. What's interesting is that it's often really hard to pin down just one single cause. The muscles, the joint itself, even your mental state, they all interact in these complex ways. In fact, some studies suggest that maybe 10 to 20% of people with TMD also have some form of psychiatric condition going on, which really highlights that link.
So given all that complexity, what's the main goal when you actually start treatment? What can someone realistically expect?
Good question. The number one goal is always to alleviate the pain and or the jaw dysfunction. Basically, improve your quality of life.
Makes sense.
But that raises a really important point about expectations. While improvement is very likely with treatment, getting rid of all symptoms completely is honestly probably an unreasonable expectation in most cases. It's more about effective management, finding significant relief, not necessarily a total cure forever.
That's a really crucial distinction for people to understand. Okay, and what about those noises, the clicking, the popping sounds that people often notice? Should we worry about those?
Yeah, that comes up a lot. Clicking and popping in the TMJ are actually pretty common. You even find them in completely normal joints that aren't causing any pain or problems.
Oh, really?
Yeah. So the general thinking is, if you just have joint noise, but no pain or difficulty using your jaw, it generally doesn't need any intervention.
Okay.
It's when those noises come with pain or you find you can't open your mouth properly that it becomes a real concern.
Got it.
And because it is so complex, like we said, you often need a multidisciplinary approach, a whole team. Oh, dentists, obviously, but also physical therapists, maybe orthodontists, neurologists, psychologists, or psychiatrists, even anesthesiologists and oral surgeons in some cases.
Wow, that's a serious team effort, which really underlines how involved TMD can be. And then this is where it gets really interesting for a lot of listeners, I think. The idea of surgery can be pretty daunting. What's the evidence say about the non-surgical stuff?
Right. And this is the powerful promise, really. The research actually suggests that these non-surgical treatments have a really high favorable response rate. We're talking as high as maybe 74% to 85%.
74 to 85%. That's huge.
It is. Think about it. There was one study where 81% of patients showed at least a 50% improvement or better after just conservative physical therapy within 6 months.
That's incredibly encouraging.
Yeah.
So people should feel pretty optimistic about starting with these more conservative options first.
Absolutely. The general takeaway seems to be that almost all patients with TMD will see improvement over time, regardless of the specific type of treatment they get. This long-term improvement trend is key. And actually, it's one reason TMD can be challenging for surgeons because most symptoms do respond really well to conservative management.
Ah, okay.
So, non-surgical therapy is almost always the first line of defense. It often comes before, and definitely always follows, any kind of surgical intervention, if that even becomes necessary.
That makes perfect sense. Okay, so let's dig into some of these foundational non-surgical strategies, starting with something really basic, like how you eat.
Yeah, the soft diet. It sounds simple, but it's a really critical component for giving the jaw some rest.
Okay.
It helps prevent overloading that TMJ, and it can decrease muscle hyperactivity. So, you want to divide foods into smaller pieces.
Right.
And strictly avoid anything really chewy, hard, or crunchy.
Yeah.
Yeah, that means maybe skipping tough meats, raw carrots, that kind of thing for a while.
Even gum, I guess.
Oh, definitely avoid gum. And in really severe flare-ups, some people might even need a strict liquid diet for a short time just to really, truly give the jaw a break.
That sounds like a pretty immediate change many folks could try. And what about tackling the underlying tension or stress, especially since we know psychological factors can play a part?
Yeah, stress reduction and relaxation techniques can be very effective. We're talking about strategies like progressive muscle relaxation.
Where you tense and release muscle.
Exactly. You systematically work through different muscle groups. Also, synchronized breathing exercises, guided meditation, even listening to relaxation audio tapes. It's all about teaching your body to unwind, which can directly impact that jaw tension.
And I've heard about biofeedback being used too. How does that work?
Right, biofeedback. It basically helps you become aware of and learn to control bodily functions you're usually unconscious of, like muscle tension.
Wow.
Well, you use tools, maybe like EMG sensors that measure muscle activity or skin temperature monitors. They give you real-time feedback.
Oh.
So you can literally see or hear when your muscles are tense, and then you learn techniques to consciously relax them. And it seems to work pretty well. One review found that 69% of people rated their symptoms as improved or even symptom-free after biofeedback and relaxation, compared to only 35% who got a placebo.
Wow. 69 versus 35%. That is a big difference.
It really is. Shows the power of gaining that conscious control.
Are there any sort of alternative or complementary therapies that people find helpful sometimes as additions?
Acupressure and acupuncture often come up as complementary options. The traditional idea involves, rebalancing energy flow or Kia. A more modern take is that they might work by stimulating certain nerves, maybe triggering the release of natural pain relievers like endorphins or affecting brain waves.
And does the evidence support them?
Well, some studies do show favorable results, especially when they're combined with other treatments. But overall, the data is still a bit limited. They're usually seen as something you might add on to other therapies, not necessarily a standalone fix.
Okay. And given that strong link to psychological factors we talked about, where does something like psychotherapy fit into the picture for TMD?
It can be crucial. Psychotherapy really acknowledges that TMD can be tied to underlying psychological issues. So clinicians should probably screen for personal or family history of psychiatric conditions or things like past trauma or substance abuse.
Right.
Treatments might include things like behavioral therapy or cognitive behavioral therapy, CBT. That helps you change thought patterns and behaviors that might be contributing to your pain.
Okay.
And for really long-term or severe cases, sometimes a referral to a specialized pain center, which often incorporates psychological support, is the best way forward.
All right, let's move on to the pharmacological arsenal. Sometimes you just need some relief, right?
Yeah.
What are the general principles when thinking about medications for TMD?
Yeah, medications definitely have their place, but the key thing to remember is that they're almost always adjunctive, meaning they're supports, not cures in themselves. They help manage symptoms alongside other therapies. And it's really crucial to be aware of the potential danger of drug dependency or abuse, especially with stronger pain relievers like narcotics.
That's a really important point.
Absolutely. So the general recommendation is usually to prescribe medications at regular intervals for a specific limited time, not just as needed whenever you feel pain, because that pattern can sometimes encourage overuse or dependence.
Right. Taking it on a schedule for a set period makes sense. So what kinds of pain relievers are typically used?
Well, for general pain relief, the first step is often the common over-the-counter options like aspirin or acetaminophen, Tylenol. They can also have some anti-inflammatory effects.
Okay.
If the pain is more moderate to severe, A doctor might prescribe an opioid analgesic, something like oxycodone or hydrocodone. But, and this is a big but, it's vital to emphasize that their use should be for a very limited duration.
So limited.
Typically, we're talking maybe 2 to 3 weeks max because of that high potential for addiction. They're for acute, severe pain, not long-term management.
Got it. And beyond just blocking pain, inflammation seems like a big part of TMD for many people, doesn't it?
It often is, yes. Which is where anti-inflammatory medications really come in handy.
Like NSAIDs.
Exactly. Non-steroidal anti-inflammatory drugs, NSAIDs, things like ibuprofen, naproxen, diclofenac. They're useful because they have that dual action. They relieve pain and they reduce inflammation.
So good for things like joint inflammation, arthritis.
Precisely. Synovitis, osteoarthritis, they can be helpful for those conditions. Of course, you always need to be mindful of the typical side effects like stomach irritation.
Right, taking them with food helps?
Yes, taking them with food, sometimes with antacids. There are also specific types like COX-2 inhibitors designed to be a bit gentler on the stomach, though they have had some cardiovascular concerns raised in the past.
Okay. And what about corticosteroids? Are they used?
Corticosteroids, yeah. They offer a more pronounced anti-inflammatory effect compared to NSAIDs. But systemic use, taking them as pills, is generally kept very short term.
Why is that?
Because of the risk of pretty severe long-term complications if used for extended periods, things like osteoporosis, diabetes, immune suppression. So maybe just a 5 to 7 day course for a significant flare-up.
And injections. Can they inject steroids into the joint?
They can, yes. Local injections directly into the TMJ can be effective, but again, there are risks with doing it too much or too often. Excessive use has been linked to potential issues like condylar hypoplasia, which is where part of the jawbone doesn't develop properly, so careful use is key.
Okay. Now, given the links we discussed earlier between stress, anxiety, muscle tension, and TMD, are there medications specifically aimed at those things?
Absolutely. For anxiety and related muscle hyperactivity, sometimes benzodiazepines are prescribed diazepam, for example, Valium. They help reduce anxiety, they relax skeletal muscles, and they can also help with things like insomnia or bruxism, that teeth grinding.
But they have dependency issues too, right?
They do, yes. Very high potential for dependency. So similar to opioids, their use should really be limited, typically to about 2 weeks or so. There are other options like Buspar, which can help with anxiety without causing sedation or muscle relaxation, but benzos are often used for that short-term muscle relaxation effect.
What about antihistamines? I sometimes hear about those.
Yeah, some antihistamines like promethazine or hydroxyzine have sedative and anti-anxiety effects. They don't have the same abuse potential as benzodiazepines, so they can sometimes be a safer option, especially maybe in children or the elderly.
And if chronic pain or even depression is part of the picture, you mentioned antidepressants earlier.
Yes, exactly. Certain antidepressants, particularly the older tricyclic antidepressants like amitriptyline, are often used for chronic pain conditions, including TMD-related headaches, and also for sleep disorders.
Even if the person isn't clinically depressed?
Yes, interestingly, even at low doses, these TCAs seem to have an analgesic or pain-relieving effect that's independent of their antidepressant effect. It's quite useful. This is especially relevant since, as we noted, maybe up to 30% of TMD patients also experience major depression.
Okay.
Newer antidepressants, the SSRIs like Prozac, are sometimes used too, but there's a caution. They can occasionally increase bruxism or anxiety in some people, so it needs careful monitoring.
And what about straightforward muscle relaxants?
Yep, medications like cyclobenzaprine are specifically designed to target muscle hyperactivity and can be very effective for acute myofascial pain, that muscle-related jaw pain. Others like baclofen might be used for more severe spasm or nerve-related pain. Even botulinum toxin, Botox, is sometimes used off-label for severe bruxism by injecting it into the chewing muscles.
Wow, Botox too. And finally, what about local anesthetics? How are they used?
Local anesthetics, like what you get at the dentist, work by temporarily blocking nerve impulses. In TMD treatment, they can be used diagnostically, injecting a specific area to see if the pain goes away, which helps pinpoint the source. Or they can be injected directly into muscles, trigger points, or even sometimes into the joint itself to provide temporary pain relief and allow for an increase in range of motion. They also have a vasodilator effect, which can improve blood flow to the area.
Okay, That's a really thorough overview of the pharmaceutical options. Quite a range. Now let's shift gears and move into the physical therapy toolbox, because it sounds like movement, heat, even electricity can play a huge role here.
Absolutely. And if we connect this back to the bigger picture, physical therapy and exercise are really core components of pretty much any TMD program.
Why are they so central?
Well, partly because prolonged jaw immobilization, just not moving your jaw much because it hurts, can actually have really detrimental effects on both the joints and the muscles. It can lead to more stiffness, more pain, less function down the line.
Right, use it or lose it kind of thing.
Sort of, yeah. Gentle, controlled movement is often key to recovery.
So what does a typical home care program look like then? Maybe for milder or more acute symptoms that someone could start with.
Okay, for mild or acute symptoms, a basic home program often starts with that soft diet we talked about, consciously resting the jaw, alternating heat and ice packs on the painful areas, usually heat for muscle soreness, maybe ice for acute inflammation, and then specific gentle exercises.
Like what kind of exercises?
Things like practicing good jaw and tongue posture, tongue up, teeth slightly apart, lips together, gentle side-to-side jaw movements, staying within a comfortable range, and some passive stretching exercises. The key is always controlled. Gentle movement aimed at restoring normal function without causing more pain.
Okay. And are there different sort of types of jaw exercises that a therapist might use?
Yeah, we generally group them into passive, active, and isometric exercises.
Can you break those down?
Sure. So passive exercises involve using some kind of gentle external force to help increase the jaw opening. That could be your own hand applying gentle pressure, or sometimes specific devices like a Therabite machine.
Okay. And what are those good for?
They're very effective for muscular stiffness, what we call trismus, maybe after surgery or just from muscle guarding. But you have to be cautious using them if there's a severe issue with the disc inside the joint being out of place.
Got it. What about active exercises?
Active exercises are movements initiated entirely by you, the patient. So, for example, activating specific muscles to help relax others, like using the muscles under your chin to help relax the main jaw closing muscles. Or it might involve gently opening your mouth just to the point before you feel pain, holding it briefly, and repeating that several times throughout the day.
So you're gradually coaxing more movement.
Exactly, gradually increasing your pain-free range of motion. And then there are isometric exercises.
And those are?
Those are used typically when there's more severe pain or stiffness. You gently activate muscles, say the muscles that open the jaw, by pushing against resistance, like your hand under your chin, but without actually moving your jaw.
Why do that?
The idea is that activating one set of muscles can help trigger a relaxation response in the opposing muscles in this case, relaxing those tight jaw-closing muscles without having to force movement through pain.
Interesting. It sounds like there's a lot of nuance just in the movement part.
Yeah.
What about hands-on therapy from PT manual therapy?
Yeah, manual physical therapy is a big component. This includes soft tissue techniques, things like massage, myofascial release, specific stretching techniques applied by the therapist, and also manipulative therapy. This can involve mobilizing the jaw joint itself or even addressing issues in the cervical spine, the neck, given how closely connected the neck and jaw muscles and nerves are.
Right. Neck problems can definitely refer pain to the jaw.
Absolutely. Sometimes rapid manipulations might give immediate relief, but it can be temporary. And success rates for trying to manually recapture a significantly displaced disc can sometimes be low.
Okay. And how do thermal agents, heat and cold, fit into the physical therapy plan?
They're used a lot. Heat therapy, especially moist heat, like using a warm, damp washcloth or those hydrocollator packs they have in clinics, is great for reducing muscle pain.
How does it work?
It works by increasing blood flow to the area of vasodilation. This helps flush out inflammatory chemicals that contribute to pain, and it just generally soothes sore muscles. Very effective for that myofascial, muscular type of pain.
And cold. Cryotherapy.
Cryotherapy or cold therapy is used a bit differently. It can help facilitate muscle stretching, and it also helps inhibit pain perception. It does this partly by stimulating certain nerve fibers, kind of overriding the slower pain signals from other fibers.
I've heard of stretch and spray.
Yeah, that's a common technique using cold. A therapist might use a refrigerant spray to quickly cool the skin over a tight muscle, which momentarily reduces pain and spasm, allowing them to stretch the muscle more effectively right after.
Any downsides to cold?
While sometimes cold can temporarily increase joint stiffness, so it's used cautiously over the joint itself, often cryotherapy is followed by moist heat to get the benefits of both.
Okay. Are there ways to get heat deeper into the tissues?
Yes, there are deep heat modalities. Ultrasonography is one. It uses sound waves that convert to heat when they penetrate soft tissues.
What does that do?
That deep heat increases blood flow, helps clear out those inflammatory mediators we mentioned, decreases pain, and can increase tissue mobility. It might be particularly beneficial for, say, tightness in the joint capsule itself. There's also something called phonophoresis. That actually combines ultrasound with applying a medicated cream, like a steroid or an anesthetic, to the skin. The ultrasound waves supposedly help drive the medication deeper into the tissues, useful for things like synovitis, where there's painful, limited jaw movement.
Wow, using sound to deliver medicine. And what about electrical stimulation? That sounds pretty high-tech for jaw pain.
It does, but it's actually used quite a bit. TNS, which stands for transcutaneous electrical nerve stimulation, is probably the most common.
What is TNS?
It involves placing electrodes on the skin over the painful area and delivering a low-voltage electrical current. It works partly on that gate control theory of pain, essentially distracting the nervous system from the pain signal.
Okay.
It can help decrease muscle pain and hyperactivity, and it's sometimes used for neuromuscular re-education, helping muscles fire more normally. 10NS units are often portable, so patients can use them at home.
Are there other types of electrical stimulation?
Yes, there's also high-voltage stimulation, which uses stronger currents. Depending on the settings, it can be used to reduce nerve irritability or sometimes to help soften tight tissues and decrease muscle spasm. It can improve jaw mobility and pain.
I think there's one more, iontophoresis.
Right, anaphoresis. This also uses a low-level electric current, but its specific purpose is to transfer drug ions, like from dexamethasone, a steroid, or lidocaine, an anesthetic, through intact skin directly into the underlying tissue.
So another way to deliver medication without an injection.
Exactly. It can be effective against inflammation, muscle spasm, maybe even some calcium deposits.
That's quite a toolbox for PT. One last thing in this area, what about injections into the muscles themselves, trigger point injections?
Yes, trigger point injections are definitely part of the toolkit, often done by physicians or specially trained therapists. This involves injecting a small amount of local anesthetic, usually without epinephrine, directly into those hyperirritable knots or trigger points within a muscle band.
And the goal there?
The anesthetic helps to break the pain cycle originating from that trigger point. This allows for more effective stretching of the muscle immediately afterward, and the improved blood flow helps clear out the metabolic waste products that can accumulate in those tight spots and contribute to pain.
Okay, that gives us a fantastic picture of the physical therapy approaches. Now, let's shift to those specialized dental devices you mentioned earlier, occlusal appliance therapy. What's the main idea behind using those?
Right, occlusal appliances, which most people probably know as splints or nick guards, although they can be more complex than a simple nick guard. They're custom fit, usually removable devices that you wear over your teeth.
And what are they trying to achieve?
The primary goals are generally to decrease the loading or stress on the TMJ itself, and also to reduce neuromuscular reflex activity, basically, calming down overactive jaw muscles. They're often used to address issues like bruxism, that teeth grinding or clenching, and the myofascial pain that often comes with it.
Okay. So what are the main types of these appliances people might encounter?
Broadly speaking, there are two main categories. The first, and probably most common, is the stabilization appliance, sometimes called a flat plane splint.
What's that like?
It's usually made of hard acrylic, and it covers all the teeth in one arch, typically the upper jaw, though sometimes the lower. It provides a flat, smooth surface for the opposing teeth to contact evenly.
And how long do you wear it?
It can vary, sometimes just at night, but in some cases up to 24 hours a day initially, especially if used after surgery or for significant pain.
What are its goals?
The main goals are to relax those overworked masticatory muscles, help stabilize the joint by allowing the condyles, the ends of the jawbone, to seat in a more comfortable, stable position, and also physically protect the teeth from the forces of bruxism.
Okay. Sounds pretty straightforward. Does it work well?
It can be quite effective, particularly for muscle-related pain and headaches associated with TMD. However, there are considerations. Well, ideally, once symptoms improve, you should be gradually weaned off wearing it full-time or maybe just transition to nighttime wear. If worn constantly for too long, it can potentially lead to unwanted changes in your bite, what we call iatrogenic malocclusion. a bite problem caused by the treatment itself.
Oh, okay. So careful monitoring is needed.
Definitely. And it's worth noting that its effectiveness for certain joint-specific problems, like a desk that's displaced without clicking back into place, is more mixed. Some studies have even suggested it might potentially increase osteoarthritic findings in some cases, though that's debated.
Interesting. Okay, what's the other main type of appliance?
The other main category is the anterior repositioning appliance.
How is that different?
This type of appliance has ramps or indentations built into it that actively guide your lower jaw into a more forward or anterior position when you close.
Why would you want to do that?
The primary goal here is usually to alter the relationship between the condyle, that disc inside the joint, and the socket, the fossa. By moving the jaw forward, the aim is often to recapture a displaced disc or simply decrease the load on the painful joint structures. It's mainly intended for specific types of internal derangement within the joint.
That sounds like it could have a more significant impact on how your teeth meet.
It absolutely can, and that's the main drawback. These anterior repositioning appliances are generally used less frequently these days, precisely because they have a higher potential to cause irreversible changes to your bite.
Like what kind of changes?
Most commonly, they can lead to a posterior open bite, where your back teeth no longer touch when you bite down without the appliance in. Correcting that often requires extensive orthodontic or restorative dental work, so they're used much more cautiously.
That makes sense. So these appliances try to create a better temporary position. What about just permanently changing the bite itself, like grinding down teeth to make them fit better? Occlusal adjustment.
Yeah, occlusal adjustment, which involves selectively reshaping the enamel of certain teeth. This used to be done more often, but it really has a very limited role in TMD management today, and there's generally a lack of strong supporting evidence for using it to permanently reposition the jaw.
Why the limited role?
Well, mainly because it's an irreversible procedure. You're permanently removing tooth structure, and the evidence just doesn't robustly support the idea that minor bite discrepancies are a primary cause of most TMD problems. It's usually only considered truly appropriate in very specific situations, like maybe an acute TMD problem that clearly started immediately after some recent dental work that left a high spot, or perhaps post-surgically if there are very obvious problematic interferences, but not as a general TMD treatment.
Okay, good to clarify. So we've covered a lot of ground on the main non-surgical approaches. But what happens if, someone tries these things and they're still really struggling? Or what if surgery does eventually become necessary? Are there other, maybe more advanced non-surgical things to consider, even in those situations?
That's a really important question because even if surgery is on the table or if initial therapies aren't fully working, there are still important considerations that are technically non-surgical but often interface with more complex management or surgical planning.
Like what?
Well, one key concept, especially relevant if surgery is being considered, is something called preemptive analgesia.
Preemptive analgesia.
Yeah.
Sounds like getting ahead of the pain. Pain control before it even starts.
That's exactly the idea. It's about administering pain control before the surgical stimulation, before the first incision.
Why is that timing so critical?
It relates to this concept called neuroplasticity. The idea is that intense noxious stimulation, like from surgery, can actually induce dynamic, sometimes lasting, changes in the central nervous system pathways that process pain. This can make you more sensitive to pain afterwards, potentially contributing to chronic post-surgical pain.
Wow.
So, preemptive analgesia aims to block those central nervous system changes from happening in the first place by having pain control already on board before the stimulus hits.
What kinds of things are used for that?
It often involves a combination of approaches. Things like neural blockade using local anesthetics, maybe opioids given before surgery starts, certain receptor antagonists like ketamine, or even non-opioid analgesics like ketorolac. The key is they must be administered before the noxious stimulation begins.
Is there good evidence it works?
Yes, actually. Studies in various types of surgery like tonsillectomy, even major bone harvesting from the hip, have shown significant reductions in post-surgical pain when preemptive analgesia is used. It's even been shown to help prevent phantom limb pain in amputees.
That's incredible. So it's highly recommended before TMJ surgery.
Definitely. Using things like opioid-based general anesthesia combined with regional nerve blocks before the surgery starts, and maybe even re-anesthetizing during long procedures, is considered best practice to minimize that central sensitization and hopefully reduce post-op pain.
That's a really profound concept, preventing pain pathways from even getting established. Okay, what about another advanced issue? Maybe something after surgery, like preventing unwanted bone growth.
Right, ectopic bone formation. This is a potentially serious post-surgical complication, especially after certain types of TMJ surgeries like joint replacement or extensive reconstructions.
What is ectopic bone?
It's basically bone growing where it shouldn't in the soft tissues around the joint.
Yeah.
This can severely restrict jaw movement and cause chronic pain, sometimes requiring further surgery to remove it.
So how can that be prevented non-surgically?
Well, two main strategies have been explored. One is low-dose radiation therapy.
Radiation.
Yes, typically giving low doses, maybe 10 to 20 gray, delivered in fractions, usually starting within about 4 days after the surgery. The idea is that radiation inhibits the proliferation of those precursor cells that eventually turn into bone-forming cells, the osteoblasts. Some case studies have suggested it can help maintain better jaw movement after complex surgeries.
Radiation therapy sounds pretty serious, though. Are there major concerns with that?
That is the critical concern, yes. The major worry is the long-term potential for inducing neoplasia new growths, potentially cancerous. Studies looking at, for instance, childhood scalp radiation for other conditions showed a significantly increased risk, like a 7-fold increase in neural tumors and a 4.5-fold increase in other malignancies, often with a very long latency period decades later.
And the TMJ radiation studies?
They typically have much shorter follow-up times, maybe 9 years at most in published reports. So the true long-term risk after TMJ radiation isn't really fully known yet, which makes it a significant concern, especially in younger patients.
That definitely sounds like something to weigh very carefully.
Mm-hmm.
Is there a less invasive alternative to radiation for trying to prevent this ectopic bone?
There is. NSAID therapy using non-steroidal anti-inflammatory drugs has also been looked at.
How would NSAIDs prevent bone growth?
The exact mechanism isn't perfectly clear, but it's thought they might work by inhibiting certain inflammatory responses that are involved in triggering that abnormal bone formation. Studies, particularly from the world of hip replacement surgery, have shown that certain NSAIDs, like indomethacin, can actually be as effective as low-dose radiation in preventing ectopic bone there.
And for the TMJ?
Well, there aren't, to my knowledge, specific large-scale studies reported just for the TMJ comparing NSAIDs to radiation for this purpose. Given the effectiveness in hip surgery and the significant concerns about radiation, it seems prudent to consider using NSAIDs post-operatively for this reason. Of course, you still have to be vigilant about potential GI or renal side effects from the NSAIDs themselves.
Okay, NSAIDs as a potentially safer alternative. Good to know. And maybe one final complex area to touch on briefly. A rare but severe pain condition called sympathetically maintained pain, or SMP. What is that?
Right, SMP. It's also often referred to now as complex regional pain syndrome, or CRPS type I. It's characterized by this really severe, continuous, often burning pain, usually following some kind of traumatic injury, even seemingly minor one sometimes.
And it involves the sympathetic nervous system.
Yes, it's associated with abnormal activity in the sympathetic nervous system, the part that controls things like blood flow and sweating. Patients often have a really striking cluster of symptoms. Well, studies show things like weakness in almost everyone, 95%, the intense pain, 93%, noticeable changes in skin temperature or color, 92%, really limited range of motion, 88%. It can be quite debilitating.
What's thought to be happening there?
The underlying mechanism is complex and not fully understood, but one theory involves those neuroplastic changes again. It's thought that maybe sympathetic nerve fibers actually start sprouting into sensory nerve ganglia in the spine, possibly driven by things like nerve growth factor, NGF, essentially creating abnormal connections that amplify pain signals.
How is something like that treated?
Treatment is challenging. One key diagnostic and therapeutic approach is performing an anesthetic block of the stellate ganglion, a cluster of sympathetic nerves in the neck. If that provides significant, even if temporary, pain relief, it helps confirm the diagnosis and can sometimes provide protracted relief. Other pharmacological or surgical interventions targeting the sympathetic system have had pretty inconsistent results, unfortunately. It's a tough one.
Wow, okay. So we've covered this huge range of non-surgical options, from basic home care to these really advanced considerations. But let's bring it back. What does this all mean if you, the listener, have tried some of these things and you're still struggling? Why does non-surgical therapy sometimes fail?
Yeah, that's a really important reality to address. It's true, sometimes these approaches don't bring the relief people hope for. And assessing failure itself is tricky because, as we've seen, there are so many different options and there aren't even universally agreed upon diagnostic criteria for all types of TMD.
Right.
But we can definitely pinpoint some key reasons why non-surgical therapy might not succeed in some cases.
What are some of the main ones?
Well, first off, improper diagnosis or treatment planning, given how complex TMD can be, getting the diagnosis right and choosing the most appropriate initial treatments is crucial, and sometimes that gets missed.
Okay, that makes sense. What else?
Another really major factor is, unfortunately, lack of patient compliance. And this is a really big one for you, the listener, to think about honestly.
What do you mean by compliance?
Things like sticking with that soft diet consistently, doing the prescribed home exercises or stretches diligently every day, using heat or ice packs regularly, wearing a bite splint as instructed, attending physical therapy appointments.
Right, all the things we've been talking about require effort.
They require significant effort and diligence. And the problem is, improvement with these conservative measures is often slow and gradual. It's not an overnight fix. So it can be really easy to get discouraged and just abandon the treatments before they've had a real chance to work.
Yeah, I can definitely see how that would happen. It's tough to stick with something if you're not seeing immediate results, especially when you're in pain.
Exactly. Emotional and psychological factors also play a big role. It can simply be more challenging to achieve success in patients who are emotionally debilitated, dealing with major depression, significant anxiety, or other comorbidities that complicate the picture. Then there are practical barriers. Maybe someone gets significant GI upset from NSAIDs and has to stop taking them. Or they have trouble finding a dentist skilled in making and adjusting occlusal appliances properly. Or difficulty accessing a physical therapist who has specific experience treating TMD. These things can definitely hinder progress.
And you mentioned earlier that sometimes treatments can make things worse initially.
Yes, that can happen too. Sometimes, for example, when you first start wearing a bite splint, it can actually cause a temporary increase in muscle soreness or joint pain as your jaw adapts to the new position. If someone isn't prepared for that possibility, they might understandably get frustrated and stop wearing it, thinking it's making things worse, when maybe it just needed a little more time or a slight adjustment.
So it sounds like even when things aren't working perfectly, the message is really to stick with it and communicate with your provider.
Absolutely. Persistence is so key here. The reality is the vast majority of patients with TMD will never become candidates for surgery. So continuing to work through and optimize non-surgical treatments is really vital.
And if things really aren't improving after a decent try,
then it's time for reassessment. If there's really no significant improvement after, say, 3 to 6 months of consistent, well-managed conservative therapy, then it's definitely necessary to revisit the diagnosis, maybe consider further diagnostic tests like an MRI to get a better look at the joint structures and potentially explore different or more advanced non-surgical options, or perhaps reevaluate if other contributing factors have been missed.
this has been an incredibly comprehensive deep dive, really navigating the whole landscape of managing TMD without surgery. We've explored such a vast array of options, haven't we? From the simple things like home care and stress reduction, all the way through advanced PT, the whole pharmacy of potential medications, and those specialized appliances.
Yeah, and if we try to connect all this back to the bigger picture, I think what really comes through is that TMD is truly a complex, often multi-system disorder. There usually isn't one single magic bullet. But the overwhelming message, I think, is also one of hope. It highlights the body's incredible capacity to heal and adapt, especially when it's given the right kind of support consistently over time. It really underscores the power of things like patience, perseverance, and taking that comprehensive multidisciplinary approach we talked about. Your journey into managing TMD is unique to you, and just understanding all these different options we've discussed is hopefully your first empowering step towards finding effective, lasting relief.
That's a great way to put it.
Yeah.
So as you've been listening, what stands out to you from this deep dive? Which of these strategies maybe resonated or perhaps sounds like something you might want to explore further or definitely discuss with your own healthcare provider? Yes. Keep digging, keep learning, and importantly, keep advocating for your own health. Thanks so much for joining us on the deep dive.